A 40-year-old presents with knee discomfort. I am showing you the radiographs of the right knee and lower leg. Describe the findings.
Okay, looking at the images, the radiographs of the right knee, tibia, and fibula demonstrate marked, dense cortical thickening, affecting the diaphyses of the tibia and fibula. This hyperostosis has an undulating, flowing appearance along the outer cortex, resembling dripping candle wax. Additionally, there are multiple small, well-defined round to ovoid sclerotic foci clustered in the metadiaphysis of the distal femur and proximal tibia. These sclerotic foci measure a few millimeters in size and are oriented parallel to the long axis of the bones. The combined findings are diagnostic of Melorheostosis and concurrent osteopoikilosis.
Explain the radiological signs, inheritance, and pathophysiology of Melorheostosis.
In that case, Melorheostosis is a rare, non-hereditary, benign, sclerosing bone dysplasia of unknown etiology. Its hallmark is flowing hyperostosis along the cortex of tubular bones, classically described as the dripping candle wax appearance. The sclerosis is asymmetric, usually involving only one side of a limb, and is distributed along a single sclerotome. It predominantly affects the lower extremities and diaphyses of long bones and can cross joints, leading to ankylosis and contractures.
I am showing you a comparison humerus radiograph. Describe its findings and how it relates to this condition.
Well, the comparison anteroposterior radiograph of the shoulder shows dense, flowing cortical hyperostosis along the humerus shaft and the scapula. This illustrates a classic, severe presentation of Melorheostosis in another patient where the dripping candle wax appearance is highly pronounced. Note that the sclerosis remains unilateral and confined to a single extremity sclerotome, sparing the contralateral skeleton. This case highlights that while lower limbs are most common, the upper extremity can also be affected.
What is osteopoikilosis, and what are its key imaging features and genetic background?
Okay. Osteopoikilosis, meaning spotted bones, is a benign autosomal dominant sclerosing dysplasia caused by LEMD3 gene mutations. It is characterized by multiple small, symmetric, ovoid sclerotic bone islands measuring 2 to 10 millimeters. These bone islands are clustered symmetrically at the metaphyses and epiphyses of long bones, pelvis, hands, and feet. They run parallel to the trabecular path, are completely asymptomatic, and do not demonstrate increased uptake on bone scintigraphy.
What is the clinical significance of these conditions, and how would you manage this patient as a radiologist?
The primary clinical importance of osteopoikilosis is that it can be mistaken for widespread osteoblastic metastases, or myeloma. Widespread metastases from prostate or breast cancer would show asymmetric distribution, involve the axial skeleton, and display hotspots on a bone scan. As a radiologist, I would reassure the referring clinician and patient that both Melorheostosis and osteopoikilosis are benign, incidental findings requiring no active intervention. If clinical symptoms of contracture or pain occur in Melorheostosis, physical therapy and referral to orthopedic surgery are appropriate.